Good morning, everyone. The topic for today's seminar is step-by-step approach in implant placements, first stage surgery. It will be covered in the following contents. Coming to the introduction, the technique for dental implant surgery has evolved over the years from the original protocol pioneered in 1970 by Brenmark, a Swedish physician and researcher. Today, with the integration of the computer and digital technology, dental implant clinicians now have full array of choices for the placement of the dental implants. Now, before doing any of the implant surgery, first you need to radiographically diagnose and assess the bone. How do you radiographically diagnose? It's basically either you take a CVCT or a computer tomography. Now, this computer tomography will give you certain values in the form of Hounsfield units. Now, if suppose say the D1 bone is present, so the Hounsfield units will be greater than 1250. If say suppose there is a D4 bone present, the Hounsfield units will be accordingly like 150 to 350. So usually, as we all know, the anterior mandible has a D2 type of a bone. Each type of a bone, that is D1, D2 to D4, we will study individually. The anterior maxilla has a D3 type of a bone. The posterior maxilla has a D4 type of a bone. The posterior mandible has D3 type of a bone. So what is this D1, D2, D3, and D4? The D1 type of a bone is a dense cortical bone, which is basically present in the anterior mandible. D2 type of a bone is a vine, pine, or spruce wood type, which is present in the anterior mandible and posterior mandible. And D3 type of a bone is a type of a porous cortical and a fine trabeculae, which is present in the anterior maxilla and posterior maxilla. D4 is a fine trabeculae, that is a striatum type of a bone, which is usually present in the posterior maxilla. So now, a study was done by Shinman et al. And he found the survival rate which was related to the bone density, and he found that the anterior maxilla and the posterior mandible had a highest success rate of the implant when compared to that of the posterior maxilla because of the type of bone which is usually present in that area. So now, whenever you talk about the site of implant placement, it can either be a maxilla or a mandible. When you talk about the maxilla per se, it is the force distribution unit. Okay, and when we talk about the mandible, mandible is a bone absorption unit. So all the forces which are there in the mandible are absorbed, whereas in maxilla they are distributed over the trajectories of the skull. So now coming on to the surgical approach, it can either be a field guided or it can be guided. Okay, in guided also they can either be bone supported, tissue supported, or tissue supported. Bone supported is basically when you use a stent, okay, it is supported by the bone. Okay, second is the tissue supported. Tissue supported, either when we open a flap, it is supported by the tissue, or it will be either a tooth supported. And the guided can be further divided into the pilot template, universal template, fully guided template, as well as a navigational directed surgery. Now, before we start with any implant placement, we need to assess the amount of the bone. Okay, we assess using bone mapping. Okay, we take a endodontic file. Okay, 30 number or 35 number. We usually penetrate through the mucosa and check the amount of the bone. With the help of this bone mapping, we made the surgical stent. So what are the instruments which are required for the surgery? Okay, we'll discuss each one in detail. The first is the instrument that is used to incise the tissue. The first is the scalpel, that is the ideal instrument for making the incision. So this is the bar Parker blade, as well as these are the different types of the this is the handle, sorry, these are the different types of blades. Okay, the usually that we use in implant is number 15 and 15C. Okay, it is either used in a pencil grasp or a palm grasp. Okay, it can either be used in both the grasp. We usually prefer this pencil type of a grasp. Coming to an instrument which is used to reflect the tissue. Now this is called as a mold periosteal elevator. Okay, this can be used in three motion, that is the prying motion, push motion, pull, or scrape stroke. Okay, the prying motion is pointed. Okay, that is used in the prying. Okay, that is basically used to elevate the soft tissue. Push is used after the full thickness incision to slide underneath the flap, or also pull or a scrape stroke, which is used to remove the tissue tags from the bone. the instrument which is used to grasp the tissue. It is also called as the Adson's forceps, which is used to grasp or stabilize the soft tissue during the suturing or during the implant or the bone graft procedures. There is also called Adson's forceps, which have a more aggressive type of a tool, okay, and which is used to hold a heavy or a high tension tissue. Coming on to the instruments which are used to remove the bone. There are certain instruments like Ronjo, which are used to remove the bone. This are basically the heavy duty surgical instrument with a sharp edge, scoop shaped tip, okay, and gnagging or the which is used to gnaw or snip away the bone. Okay, a burrs can also be used to remove the bone. Okay, now this Ronjo has a spring. Okay, that is basically between the handles, which increases the magnitude of the force removal. Now coming on to the instruments used to remove the tissue from the extracted socket. Okay, the surgical curettes which have this striations which are used to remove the debris and diseased tissue from the site. It's usually a spoon shape and have the sharp edges that allow the scraping of the bony walls. Coming on to the bone grafting instruments, there are certain bone graft scrapers which are basically used by the clinician to harvest the autogenous bone from one side to another side. There are also condensers which are used. Okay, this is the spoon that holds the graft, and this is the condenser that condenses the graft into the surgical site. Then you have different bone graft material like the autogenous, allogenic, xenogenic bone graft as well as the alloplast. Now the autogenous bone graft is the one which is taken up from the same individual. Okay, allogenic is the bone which is taken up by the same species but another individual, and xenograft is the one which is taken up from the another species, whereas the alloplast is the synthetic type of material which is usually manufactured like the phosphate, the glass ceramics, etc. Now, all these bone graft have certain potential like osteogenist, osteoinductive, and osteoconductive. Coming on to the another instruments like the scissor, there are different types of the scissor like Dean scissor, Iris scissor, Skelling, and Metzer balm, which is basically used to clean the tissue, separate the tissue, and even cut the sutures. Now coming on to the hemostat, the use of hemostat is to constrict the tiny blood vessels, okay, and reduce the bleeding from the surgical sites. Now there are certain instruments which are used to hold the towel drapes, which are called as the towel clamps, okay. They used to secure the instruments as well as surgical materials such as the suction tubing and the at the surgical drapes. Coming on to the handpiece and motors, okay, you have the different piezo dispenser, which is basically a console, a foot, which has a console, a foot pedal, as well as the contra-angle handpiece. Okay, and this handpiece can be 1:1 straight handpiece or 16:1 or 20:1 handpiece. That is a contra-angle handpiece. Now let us see how physio dispenser implant motor works. Now this physio dispenser has this motor. Okay, it has certain cables which are used to attach anterior as well as the posterior of to the motor, and a stand, okay, which is used to hold the handpiece, contra-angle handpiece. Now this is a saline unit which is attached to the handpiece, and there are different programs in this. Okay, so this is the handpiece, contra-angle handpiece onto which the saline unit is basically attached, which will irrigate the saline continuously at the surgical site. And this is the foot pedal. Now coming on to the sinus curettes, which are used to aid in elevation of the sinus membrane. Okay, they are the round smooth tip for lifting up the sinus and with the minimal puncture risk. Coming on to the suture instruments, the suture instrument is the basic suture instrument is a needle which has a point, the needle body as well as the swagged end. The most commonly used suture needle is in the implant dentistry 3:8 or half circle. The 3:8 needle allows the passage of the needle from the buccal to the lingual in one passage. Okay, so the half is usually used in more restrictive areas. Okay, like the maxillary molar and the periosteal for the mucogingival surgery. So there are different suture type systems, okay, as well as different are used in the implant dentistry, which are used in implant dentistry are 3 by 0, 4, 5 and 6. Coming on to the tissue picks, the goal of the tissue pick is to hold the tissue or the flap while suturing, and you need to see that you do not crush the tissue. Now there are certain asepsis protocol which you need to follow. Okay, you need to follow all the asepsis protocols so that the surgery goes smooth. Okay, so first, before everything, you need to wear your mask, you need to wear your head cap as well as your loops. Okay, then you need to wash your hand, you need to scrub the area properly, you need to remove all the dirt from the nails. Okay, you need to, with the brush, you need to remove all the dirt from the nails. Then you need to do something elbow scrubbing. Okay, now the scrub should basically be done on each of the sides, and it should be on the wrist till up till the elbow. Okay, then you need to rinse the fingertip first, then the elbow. Okay, this whole idea is to remove all the debris as well as the bacteria away from the fingertips. The scrubbing should take approximately 3 minutes. Once you have done the scrubbing, you need to dry your hand properly, otherwise you can't able to wear your scrub, or you won't be able to wear your gloves properly. Okay, surgical gloves. So first you need to drape in. Okay, then you need to wear the gloves. Okay, so wearing a gloves has also a certain technique. Okay, you need to pick up the first glove with the cuff. You need to touch the inside portion of the cuff. Okay, while holding, you need to be careful and you need to slip down the glove. Okay, and pick up the second glove with the other hand. So this is how you need to do. You need to take your help of the assistant. You need to ask him or her to tie the knot here. Okay, and your hand should be at above the waist area, which is considered as an aseptic area. Okay, then you need to anesthetize the patient. Now what you will prefer, basically you will prefer a block or infiltration. I will basically prefer an infiltration. Okay, because the infiltration will only anesthetize the nerve ending, it won't anesthetize the whole nerve trunk. Now if I take a block, it will anesthetize the trunk. So so what are the three main reasons why you place an infiltration and not block? Okay, if you place a block, say suppose in the mandible you're starting the surgery, if you place a block, you won't be able to know if you're injured her tongue or lip. Okay, in varieties of ways. But if you're given an infill, the patient will tell you, yeah, it's hurting me here because you've already given the infiltration. And if you injure the main muscles, that is the inferior or mental nerve, okay, so you won't be able to know that you have hit the major if the implant is affecting or is touching the inferior alveolar nerve. Okay, so that is what you need to remember. So now another next step is the surgical site preparation. So first you need to see how do you prepare the surgical site. Either it will be a full thickness flap or a flapless. Okay, so you need to reflect a flap. Okay, the most commonly technique that will include is the buccal, lingual, the crestal area, that is you are reflecting the flap. Other technique is the flapless surgical technique that does not reflect the crestal tissue. Okay, so now the flap design can be a type depending upon the type of incision and the type of tissue. The type of tissue can be a full thickness or a partial thickness, and the type of incision can be an enveloped flap. Okay, papilla sparing, triangular, trapezoidal, and the vestibular flap. So now coming on to the flap design. Okay, it can either be a papilla sparing surgery. Okay, now if it is a papilla sparing, what is an advantage is that there is no disruption of the papilla. Okay, and there's very much minimal disruption of the vascular tissue, but disadvantage is that there is no access to the additional site. Okay, and you need, the operator should have certain skills. Okay, then only you can perform this type of a surgery. Okay, and it's also difficult for bone grafting. as well. The second flap design is the envelope flap, okay, in which instead of giving a vertical incision, you just give a crustal incision. But the advantage is that it's easy to suture, you can easily approximate, okay. But disadvantage is that it has a limited access, okay, and it is a moderate disruption of the vascular tissue. So it's not possible for you to do the bone grafting as well in this type of a flap. The third type of a flap is a triangular or trapezoidal, in which you give the vertical incision. If you're giving a single vertical incision, it's a type of a triangular flap, and if you're giving two vertical incision, it's a trapezoidal type of a flap. The advantage is that it's a better visibility, okay, and it also increases the possibility of tension-free closure, and you have the access of the additional areas so that you can do the bone grafting basically. But the disadvantage is that patient compliance should be there, as well as the bone loss is more, as well as a recession might be seen. Third is a vestibular type of a flap, which is a less invasive type of a flap, and there's no disruption of the papilla. But disadvantage is that again the access and the visibility is less. Now coming on to the flap design requirement, okay, the flap design should provide sufficient access and necessary visualization of entire surgical area. There should be adequate access for insertion of instruments required to perform the surgery and reflect the tissue to maintain the access. Now whenever you talk about the recipient site preparation, what you do is that the process of decortication is important. What you do basically, you create multiple holes on the thick layer. Why is it done? So that you can accompany and initiate the regional accelerated phenomena. Why? Whenever you place a flap or whenever you place a flap, these new small round areas will act as a blood supply to your healing graft. So this recipient site bed preparation is very, very important aspect. So coming on to the generic drilling sequence, first drill which you use is also called as a pilot drill. Okay, that is used to initiate the osteotomy in the center of the ridge in the mesiodistal and buccolingual direction. Coming on to the ideal implant position, the ideal implant position is a minimum of 1.2 mm from the adjacent tooth, okay, and 1 mm from the another implant, and there should be at least 2 mm distance from the vital structure. Coming on to the next drill, the subsequent drill is called as the twist drill, okay, and that is used to approximate the 2.5 mm in diameter, and it's an end cutting drill which is required for the initial osteotomy. Then comes the final shaping drills that depend upon the surgical system, and the most shaping drills are used to sequentially widen the osteotomy. Coming on to the crest, module, and bone tapping drills, these are the large diameter drills that are often required as a side cutting. Now, say suppose in D1 bone, there is a hard bone, so you need to additionally drill the side, that is called as the bone tapping drills. Then comes the implant insertion. The implant insertion torque that is to be maintained is 35 to 40 NCM, and there should not be any irrigation. The advantage of inserting an implant with an handpiece is that the placement will be more ideal and less likely to deviate. So the system that we follow in our department is the ostium implant system. So whenever you talk about the ostium implant system, let us see how do we place. So first drill, that is basic. First you need to reflect the tissue. The incision is given, the pilot drill. Then the subsequent drills are basically used to widen the osteotomy site. After which the implant insertion is done. After which you need to check for the primary stability there and there, okay, and then you need to place the healing abutment or the cover screw depending upon the one stage or the two-stage surgery. Now what is this primary stability? It's a method of measuring the implant stability. um, Now this can be done using various methods like percussion testing, reverse talk testing, resonance frequency, perio testing. Okay, now this perio test value range from -4 to -2 and -4 to +2. Okay, and also the resonance frequency analysis can be used, which is instrument which is basically autoclavable, which has an calibrated transducers, and which has various frequency which are described in the ISQ values. Okay, and this values are the implant stability quotient, okay, which will give you the values of the primary stability. So this is that resonance frequency which is basically attached to the abutment, okay, and the values are basically the ISQ value, that is the implant stability quotient, is given onto the frequency analyzer. Now there is a denser burr technology, which is basically a novel biomechanical technique of which works on the technique of osteodensification, in which the bone tissue is simultaneously compacted and autografted, okay, and expanded in various directions from the osteotomy. So when a denser burr is rotated at a higher speed, non-cutting direction with a steady external irrigation, a strong and a dense layer is basically formed along the walls. You're not cutting it, you're basically compacting the bone. So these are the denser burrs. So these are basically used in the cutting mode, but when you use in the densifying mode, you basically compact the bone. Now there are certain called as bone reamers, okay, which are patient friendly and they're good alternative to the conventional ones. The basic mechanism of this reamer is that it has a one-edged blade that is situated at a specific angle. The flat end of the reamers perform a light vertical pushing motion, is basically used in the sinus floor when you are basically elevating the sinus floor. Now, when you talk about the one stage versus the two stage surgery, in which the two stage surgical protocol has various advantages, like you will submerge the implant and you will have less chances of infection. Okay, but the disadvantage is that you will have to perform the second stage. Okay, whereas one stage surgery has an advantage, you will basically use the healing abutment at there and there itself, and directly you can move with the second stage of the impression making. So in one stage you have the shorter treatment time and you do not need to perform the one stage surgery. Okay, when do you perform this one stage surgery is that when you have a favorable primary stability and there's no bone grafting as well as membrane and there's no parafunctional forces. Now coming on to the suturing technique, the last thing that we do is we need to suture and approximate the site. So there are various suturing techniques like simple loop, which are most commonly used in implant dentistry. After which you have the certain figure of 8 sutures that is placed, okay, on the buccal side, okay. The loop which is taken is from the buccal side, and on the lingual side the needle passes through the outer aspect of the flap. But the main disadvantage is that the suture material is interposed between the flap. It's basically used during the extraction site and around the papilla. Whereas when you talk about the continuous suture, okay, it basically allows for faster vascularization, and but the disadvantage is that you have the tendency of uneven distribution of tension, which may result in the loosening of the suture. Now other suture techniques are the horizontal as well as the vertical matrice suture. When you have the long edentulous span, we can use this techniques. Then you have the post-surgical medication, after which you need to basically give certain analgesic, antibiotic, antacid, anti-inflammatory mouth washes as well as a topical gel to the patient, so that the patient is pain as well as the symptom free. So what is this preemptive analgesia? The preemptive analgesia is introduced of an introduction of an analgesic regimen that is done before the onset of the noxious stimuli. Its advantage is to have adequate analgesic blood levels that is preferred, that is basically present before the initiation of the surgery. So the most commonly used is the ibuprofen, acetaminophen, and celecoxib. So you have certain thing called as a prophylactic antibiotics. The use of this prophylactic antibiotic in dentistry has been documented in the prevention of complication for the patient at the risk for development of infectious endocarditis as well as the immunocompromised patient. So disadvantage with the use of antibiotics includes the cost, the development to resistance to the bacteria as well as the adverse reaction. Coming on to the post-surgical care, the patient should be instructed onto the use of pressure dressing, and the special care should be taken to minimize any trauma to the surgical site. The patient should also avoid the rinsing of the mouth and a strict adherence to the pharmacological protocol. Sneezing, if it occurs, should be done open mouth to relieve pressure in the patient with the sinus lift procedure, as well as routine follow-up should be called every 3, 7, and 10 days. So to conclude, the bone remodeling is relation to the force exerted on it. Depending upon the location of the edentulous, there is an amount of time the area has been edentulous, the density of the bone is variable. Following the correct surgical technique and good clinical skills will always lead to success in implant dentistry. These are the references. Thank you.